Hi there. Welcome, everybody. It's great to see you. And my guest today is Michel Monje. Michel is a professor of neurology and, by courtesy, of neurosurgery, of pediatrics, of pathology, and of psychiatry and behavioral sciences. Her research lab studies the molecular and cellular mechanisms of postnatal neurodevelopment. And Professor Monje is a prominent neuroscientist and a pediatric oncologist here at Stanford. As both a research scientist and a practicing physician, Michel is advancing our understanding of postnatal brain development and then translating her findings into promising therapies for pediatric brain tumors. And I have to say that I am really in awe to what Michel is doing. She has devoted much of her career to find cure to treat kids with serious brain cancers. And in her spare time, she is also doing amazing research on how chemotherapy triggers a cascade of inflammation in the brain that leads to the so-called chemo fog. Michel is a 2021 MacArthur Fellow. The MacArthur Foundation described her as a compassionate physician committed to patient outcomes and a high-impact researcher. Monje is opening new pathways for the study of cancer pathogenesis with the potential to transform treatments of brain cancers. Michel is also a member of the National Academy of Medicine and has received numerous awards from such organizations as the National Academy of Science and the National Institute for Health. So thank you very much, Michel, for being here.
Thank you for having me.
So I guess my first question to you is, what led you to work on pediatric brain cancer, and not just any pediatric brain cancer, but one of the most aggressive cancers called the diffuse intrinsic pontine glioma, which is a horrible disease with kind of grim outcomes?
Yeah. When I was a medical student here at Stanford, I had the opportunity to take care of a child who had diffuse intrinsic pontine glioma, and that was, not unexpected, because it turns out that it's one of the most common forms of pediatric cancer. And when I took care of this little girl, I was just stunned that we could do so little for her. I was horrified by the disease. This is a cancer that arises in the brain stem, which is sort of this, if you think about the brain and the spinal cord as sort of a highway system, this is the major intersection. All of the motor fibers from the brain to the spinal cord run through the brain stem. All of the sensory fibers from the body back to the brain run through the brain stem. It's truly, this critical information, crossroads. And it's a disease that robs children, therefore, of the ability to move, of the ability to speak, of the ability to swallow, and yet it leaves them completely conscious of what's happening to them. And we have made no progress in treating this disease in 50 or 60 years. And I was just struck by how cruel it was and kind of unable to turn away after seeing it in this first child.
And how many people in the U.S. Or worldwide are affected by this?
The incidence of diffuse intrinsic pontine glioma seems pretty equal across different populations, different geographic regions. In the United States, it affects about 400 children each year. The median overall survival is less than a year, and it's a universally fatal disease. Yeah,
and what would you say were some of the key discoveries that allowed your lab to make some progress on some of this, on this terrible cancer?
I have to say that every bit of progress that's happened in this disease has really started with and come from the patients themselves. When I, decided that I wanted to study this cancer, I was encouraged not to do it because there was no way to study it. We had no experimental model systems, we had no cell cultures, we had no animal models, we had no way to ask questions in the laboratory. And so the first thing that I did as a postdoctoral fellow here at Stanford, and when I was doing my pediatric neuro-oncology training, was to begin to establish those resources. And that came from collaboration with patients. I had a patient who was a little 5-year-old boy who was dying from diffuse intrinsic pontine glioma. And his parents asked if they could donate his organs. And I said that, you know, there's limited tissue donation that's available for people with cancer, but that they could donate his tumor. And they really embraced that idea. We did an early postmortem autopsy here at Stanford, and that allowed us to establish the first cell culture of the tumor to begin to study it. And once other families heard about that, they reached out to me and asked if they could also donate. And so in this real hand-in-hand collaboration with patients and their families, we started to have tools to study this cancer, to share that really broadly with everyone in the research community. That brought more people into the field because they could ask questions, they could study it, they could do experiments. And that began, you know, our steps towards progress. Right. So that was one really critical part of making progress in this disease. The other, I think, critical, you know, in addition to the collaboration that enabled, was just taking a very different, you know, perspective on this cancer. This is a disease that occurs in a very specific location at a very specific time in childhood development. And when you take a step back and you look at the pattern of cancers in the developing childhood brain and spinal cord, they happen in specific places at specific ages, and in fact, so reliably so that if you tell a neuro-oncologist what age a child is, we can tell you where the cancer would be. And so that really speaks to something about brain and spinal cord development going wrong, and kind of suggested that we weren't maybe approaching it in the right way, that thinking about it from the perspective of cancer biology is important. We also had to think about it from the perspective of neurodevelopment and neuroscience. And that being my training, you know, that was what I did my PhD in here at Stanford. It was a useful lens to begin to try to understand it. And what we discovered, you know, using these incredible resources from patients, and taking that kind of neuroscience, you know, focus on the tumor, was that the interactions between childhood brain cancers and the brain itself and the nervous system itself critically drives the cancer. This is a group of cancers that take advantage of the growth signals that are in the developing nervous system. And in beginning to understand that, it gives us a new set of potential therapies.
Got it. And I understand that you're actually now in the middle of clinical trials for this. And so how is that going, and how are the results so far?
Yeah, so I should say that, you know, in order to effectively treat a cancer growing in the nervous system, one has to both target those vulnerabilities in the cancer cell that are intrinsic to the cancer. You have to disrupt the way that the cancer takes advantage of the environment it's in this case, the nervous system. And sort of a third pillar is to potentially use the power of the immune system, which has proven to be so effective in some kinds of cancers. And so, you know, about a dozen years ago when I started my lab here at Stanford, I tried to look at each corner of those triangles, to look at cell intrinsic vulnerabilities, to really understand how it was interacting with the nervous system, and to begin to think about ways to effectively fight it using the immune system. And what we discovered was that these cancers, kind of like glitter spread throughout Jell-O, integrate into the brain and spinal cord. They don't just diffuse that widely, they do, but they also form structural and electrical connections with the nervous system. They form bona fide synapses between the neurons that they're invading and the cancer cells. And so when you think about the challenge of trying to kind of pick out glitter from Jell-O without damaging the Jell-O, you know, the only way you can really think about doing that is with a very precise kind of seek and destroy strategy. And so, you know, fortunately, really fortuitously, as we were making those kinds of discoveries and developing tools to study these cancers and to, you know, develop laboratory models in which we could test potential therapies, there was enormous progress in the field of immunotherapy. And one of the world-leading therapists for childhood cancers, Crystal Makel, was recruited to Stanford around the time that we had discovered a really promising therapeutic target on the cancer cells. And so she and I have been working very closely together to leverage cancer cellular therapy, kind of engineered T cells that are trained, that are sort of weaponized to see one specific thing, and the thing that we train these T cells to see is on the cancer. When we put those, they're called chimeric antigen receptor T cells, when we put those CAR T cells targeting a signal that's on this particular kind of pediatric cancer into the laboratory models, it cured the mice. And it's a big step to go from mice to kids, but we began a clinical trial here at Stanford and immediately started to see some really promising results. Kids who, had their tumors shrink, kids who regained incredible amounts of neurological function, kids who came into the hospital wheelchair bound and left walking. It was really amazing to see, and we're working very hard right now to try to optimize this therapy to help it to last as long and be as durable as it needs to be, to be helpful for all children. We see some kids have a more therapeutic response than others, and we're trying to understand why and make this therapy effective for all of the kids that we're treating. But it feels like a real moment of progress. And I'm truly hopeful that this is going to help us get some durable cures.
That's amazing, really. How close are we, do you think, like in the big picture, to actually have a cure for this? Like, can you imagine, like in 50 years, people will look back and say, oh, now this is something that we can routinely cure? Or do you think it's still like it's an incredibly challenging?
I think it's closer than 50 years. We have one child on the trial who's been tumor-free for over 2 years and is thriving. We have several kids who've done very well for much longer than we would normally see. And as we understand more about why the therapy works for some and not for others, we have some really important insights already about that. We'll be able to combine, I think, this strategy with some of the other strategies we've been also, testing in clinical trials to disrupt those signals from the nervous system to the cancer that seems so important for their growth.
Look, Michelle, treating kids with cancer has got to be one of the Nobel things the Nobel jobs that one can do. But it also strikes me as one of the most emotionally difficult jobs out there. So how are you dealing with the stress, and how are you dealing with working with sick kids and devastated parents on such a regular basis?
It's taken some time to learn those strategies. It is devastating. There are times when I'm better at it than others. There are days when I cry in my office and days when, I feel I can keep enough kind of professional distance to continue to function. Having a balance between clinical care and research helps me enormously because as emotionally devastated as I might be in the clinic, I feel I can go back to my laboratory and work on that problem, that I'm not helpless, and so that helps me cope. I've worked for many years to try to compartmentalize that grief from all of the other parts of my day and the things that I need to do, and sometimes that compartmentalization breaks down. There's certain patients that, just get into, get beyond all of those protective barriers. But the lab helps me cope. My own family, focusing on them really helps me cope. And I think it's important, in some ways to let myself feel that grief, to something would be wrong if I wasn't mourning, losing these kids to this terrible cancer. But it is a lot. It's a lot to learn to do. And one thing, I'm now leading a clinical team focused on delivering immunotherapy for brain and spinal cord cancers. And we've started to have group grief counseling because I think it's really important to sit with the grief, to learn how to process it effectively, to learn how to say, I need a break, this is too much.
Yep. You're also working on curing cancer in adults, and chemotherapy triggers, I think, inflammation in the brain that leads to the so-called chemo fog or brain fog. And so before I ask you about how to treat that, could you tell us a bit about what is a chemo fog or brain fog?
Sure. So cancer therapy-related cognitive impairment, or chemo brain fog, chemo fog, is a very common syndrome of long-term cognitive impairment after cancer therapy that's characterized pretty consistently by impairments in attention, concentration, speed of information processing, executive function, and memory. And it's something that, similarly, in my own training, I was really struck by when I cared, for a patient with cancer therapy-related cognitive impairment. It seemed to be so poorly understood, much like you see the emerging themes, these sort of questions that need to be answered for patients. And I wanted to study it. And it was surprising to me that at the core of the mechanism mediating, this cognitive impairment were inflammatory mechanisms. We don't typically think about cancer therapies outside of immunotherapies as necessarily inducing inflammation. But there's a group of cells in the brain, the resident immune cells called microglia, it's a macrophage type, that are exquisitely sensitive to various forms of cancer therapy. And once microglia become reactive, they can dysregulate the interactions between various other kinds of brain cells and kind of dysregulate their ability to function well. But what's exciting about what we've learned about this so far is that it's not a destructive process, it's a process of dysregulation. And it's potentially reversible. And so that gives me a lot of hope that, there are even late after therapy that we might be able to provide therapeutic interventions.
So how does your lab develop these tools to try to treat this chemo fog then?
Yeah. So, fundamentally we have to understand both the normal interactions that mediate healthy neural circuit function and cognition, and then how cancer therapies or other immune challenges might dysregulate those processes. And what's been kind of amazing is, as we've studied the way that cells in the brain interact with each other to, enable appropriate brain function, appropriate cognition, what we've learned are principles that are dysregulated in cancer therapy-related cognitive impairment and that are hijacked by glial cancers. And so the biology, has really kind of shown us the way to study and understand these challenges. The basic biology kind of has to lead, and so we study the way that number one, the way that in a sort of healthy nervous system context, activity shapes the structure and function of circuits, and that has been something that most of the field has focused on, focusing on the big actors, focusing on the neurons and the way that they communicate with each other at synapses. But it turns out that they don't act alone, and they have incredibly important support cells. And those support cells also change structurally and functionally in response to activity. And so a major dimension of nervous system plasticity, it turns out, are in these glial cells. And so we study how that works and what it contributes to, how cancer therapies dysregulate and disrupt those critically important interactions, kind of turning plasticity into aplasticity. And then at the same time, how cancers that emerge from those very glial cells that contribute to this form of neuroplasticity hijack these mechanisms of development and learning and adaptability to enable their own growth.
Right. So this brain fog and the mechanisms that you describe kind of make it sound a lot like some of the symptoms that people that have long COVID report, this brain fog. And so is your insight that it's triggered by inflammation in the brain, and the kind of treatment you develop for the chemo fog, can it help for other things like long COVID and other diseases?
Yeah, so we're actively studying that, actually. When the pandemic began, knowing that cancer therapy-related cognitive impairment is at its core an inflammatory disease, I was very worried that this profoundly inflammogenic, immunogenic virus that seemed to induce such a dramatic immune system response, even if restricted, outside of the nervous system, if restricted to the respiratory system, that we might begin to see the same kind of cognitive impairment that is evident after cancer therapies. Because there are ways that inflammation and immune challenges outside of the nervous system are relayed into the nervous system itself. And when it was so evident early in the pandemic that a cognitive syndrome, frankly, that looks identical to what we see after cancer therapies, was affecting so many people, we decided to study this. And, in order, in the midst of the pandemic with laboratories shut down, in order to study this, of course, again, we had to come back to collaboration, and I reached out, I cold called a really brilliant immunologist and virologist at Yale named Akiko Iwasaki and said, you don't know me, but I have this idea and I would really like to work with you to test it. And so together we tested how mild COVID restricted in a laboratory model, restricted to the respiratory system. So we can engineer this experimental model to only exhibit infection in the respiratory system, to clear the virus very quickly, there's a very mild model. When we examined the brains, we saw the exact same kind of cellular dysregulation that we see after cancer therapies. And so that really gave us a hint that this might be part of the cognitive impairment and part of long COVID. And as we dug into the biology and started to collaborate with additional investigators, we had the chance to look at the brains of people who had died in New York City during the spring of 2020 and were incidentally found to have had COVID. So they didn't die from COVID, they died with COVID, and we saw the exact same kinds of cellular changes in those brains. And so it gives us a sense that part of what is contributing to cognitive impairment after long COVID can simply be the immune response to the virus outside of the nervous system being relayed to cause the same kind of cellular dysregulation that we see in other disease contexts. But I should say that long COVID is a very complex disease. There was a beautiful study just last week showing that, in some people, decreased peripheral serotonin levels because of gut inflammation can be contributing to cognitive impairment. There's other instances in which autoimmunity and other kinds of immune dysregulation can contribute to cognitive impairment. In some cases, there's direct infection of the nervous system. And so it's complex, and these mechanisms are not mutually exclusive, but part of it is, we think, this kind of reactivity of the immune system within the brain and consequent dysregulation of those interactions between neurons and glial cells that are required for healthy cognitive function.
And more generally, what advances do you hope to see in the near future, I guess, for cancer research and cancer treatment?
I think, staying in the same vein of thinking about cognitive impairment after cancer therapy and thinking about chemotoxicity in general in the nervous system, I think we're learning so much in directly related but distinct diseases like long COVID. And I think that those diseases can and conditions can really inform each other. So I'm hoping that research in chemotherapy-related cognitive impairment will inform brain fog after COVID. I'm hoping that the emphasis on understanding long COVID will help with other post-infectious disorders, and that will feed back into informing better therapeutic options for chemotherapy-related cognitive impairment and other chemotoxicities. So there's a lot of synergy, from the basic discoveries in various disease contexts. But for cancer therapy in general, I think it's a really exciting moment. I think there's been enormous advances in basic neuroscience and basic immunology that are both, directly relevant to achieving better therapies for cancer. The kind of neuroscience mechanisms that I described for brain cancers, it turns out, are not restricted to the nervous system, it's to the central nervous system, but actually the nervous system in the form of peripheral nerves really strongly affects a wide range of cancers, from breast to prostate, pancreas, skin, colon, every cancer really that's been studied, a crucial role for the nervous system has been uncovered. And so that opens up an avenue of therapies that we just hadn't been thinking about before for cancer therapies. Drugs developed for neurology and psychiatry might actually play a really important role in cancer treatment. And at the same time, there have been enormous advances in immunology and leveraging the immune system for cancer therapy, and huge strides forward in immunotherapy for some kinds of cancers, lots of work left to do for others, but it's incredibly promising.
Switching gears, I hope I can ask you a couple of questions about your personal path.
Sure.
So when we talked, you told me that when you were in high school, one of your biology teachers discouraged you from pursuing science, saying that women are just not good enough to understand the depth of science, and it actually affected your career. You ended up studying English and like English and law, even though you actually wanted to pursue science. Yeah. So can you tell us a bit about your experience?
Sure. So, growing up, I always had wanted, from as young as I can remember, I'd wanted to be a doctor. And I loved biology, and then I had a high school biology class that was, it was challenging. It was not great, and I didn't do very well on one test. And I went to the teacher afterwards and I said, this didn't go so well. Maybe I'm not studying right. What should I be doing? How can I improve? And he said, oh, don't worry, sweetheart. It's a rare woman who has a mind for science. And I remember at the time, I was about 15, I remember thinking, oh, he's just being kind. I'm not smart enough. I don't have a mind for science. And so I focused on, I also really loved, English, and I was very, long story, but maybe a little too tangential, but I was a figure skater, and I was teaching kids with Down syndrome and other neurological disabilities to ice skate, and I thought, maybe I want to do disability law. There's other things, sort of medicine adjacent I could do since I'm not smart enough in science. And I went to college at Vassar, and, wrote many essays about what we wanted to do, and I was paired with a biology professor named Kate Sussman, who read my essay and looked at my transcript and said, so what happened in biology? You got straight A's in everything, and you have like a B- or a C, and I can't even remember, in biology. And I said, oh, I just don't have a mind for science. And I remember her sitting there, and, she composed herself and she said, who told you that? Where'd you hear that phrase? And I thought about it, and I said, oh, this high school biology teacher told me that. And she said, right. Okay, so you had a bad teacher, and we're good here, and we're going to fix this. I want you to sign up for my biology class. I want you to, she gave me a whole list of things to do. And I ended up doing research in her laboratory for 3.5 years. We published a neuroscience paper together. That was really the beginning of it turned out I was fine in biology. But it felt like a save, and I still think back to that conversation and the pivot that it made in my entire trajectory. And
it would be nice if it was the one biology teacher, but you also told me that years later, when you decided, people, and you were already training in medicine, people discouraged you from having kids, and when you had kids, some people took it as a sign that you decided to give up on your scientific career altogether. Yes. And so I want to ask you, what can be done to improve the situation for women in the sciences?
Yeah, so all of that is true. When I did my MD PhD here at Stanford, I went and did residency training in the Harvard hospital system, and had really wonderful, well-meaning mentors who routinely and frequently, in an unsolicited way, told me not to have kids, and it was or that if I did, I was making a choice. And I remember thinking, well, I really want to have a family, and I really want to take care of patients, and I really want to do science, and I guess I'll try to do it all until I can't, and then I'll choose. And it turned out that time never came, that it really was possible to balance it all. And yet, as I did successfully balance it, when I was pregnant and a practicing, neuro-oncologist and doing research, people would say offhanded things like, well, I guess you've made your choices. I guess you've decided not to have a big career, in academic medicine. And I would think to myself, no, I didn't make that choice. I chose to make a new human being this year. And, I'm going to do that, and I'm going to continue to do research, and, maybe I'll delay writing this grant or writing this paper, but just wait. So how do you support women in science and medicine? Well, number one, people cannot say those things, right? People cannot impose their biases on others. Number two, we need, women in medicine and science need to be really overt role models. Whenever I give talks, I start with a picture of my daughter, one of my kids. I have four. One of my children is a baby, and I talk about neurodevelopment, and it's a great sort of opener. But really, what I'm saying is, I had kids. For everybody out there, by the way, I had kids, and it was okay. There are some really important structural things that need to happen, or I think that are happening, but could happen more quickly. There was very limited lactation space during the decade that I was having children and breastfeeding. There was limited appreciation for the time that takes. It's really important to me when people in my laboratory or in my clinical group have a child, that the lactating parent have adequate time, to do that. It takes a lot of time, and people need to have the space and the support, to do those things. It's also really important, to help people to help all new parents as they're having their kids continue their research career. And in the basic, in the laboratory, what that can mean is something as simple as hiring a full-time research assistant to be the hands at the bench while the new parent has their hands full with their baby. And that has worked incredibly well over the last, 12 or so years that I've been running a lab. I always pair new parents with research assistant. Usually it's an undergraduate who's taking a gap year. Those undergraduates go on to do incredible things, and they go to medical school and graduate school, and it's a wonderful training experience. And the graduate students and postdocs who were paired, in the lab, who were paired with this research assistant who had a new child, are able to keep their projects moving forward. They're able to learn mentoring skills, and they feel supported. I mean, I think, it's important to recognize that a large fraction of scientists leave science with the birth of their first child because the system is simply not set up to support them. There was a prospective study of this, actually published a few years ago in the journal PNAS, in which the authors followed a cohort of both male and female, students in various STEM fields, and found that 40% of women and 28% or so of men left their respective STEM fields at the birth of their first child because we just haven't set things up to support them. So I think having those structural supports in our systems is important. Giving people adequate parental leave, having affordable childcare, having space for lactation, just pretty basic, reasonable things that new parents need so that we don't lose talent from fields we need the talent to stay in.
So those are the structural changes that need to happen. And what words of advice you have for young women who are considering pursuing science?
It can all work out, and you have to believe in yourself, and you have to ignore the noise. For reasons that are unclear to me, everybody wants to share their perspective on your reproductive choices and your abilities, and you just have to ignore that. But it is a wonderful career, and it's one that is, full of flexibility for things exactly like raising a family or other personal pursuits. And so, I encourage everybody to stick with it and believe in yourself, particularly during those long years where you just have to trust your own vision of what your career is going to become, when not everybody will believe in you.
And before I open this up to questions, I'll ask you one more question. Like, what advice more generally you have for young students who want to pursue medicine, preparation, or like tips or something like that?
I think the best advice, so a couple of words of advice that I got that that were incredibly important. Number one is to do what you love. Don't do what other people want you to do. Pick the specialty, pick the scientific discipline, pick the mode of medicine or science that really gets you up in the morning, that you can't wait to get to work to do. It's a long training process. You have to love it. And when you love it, it doesn't feel like work. The other thing that someone said to me early in my career that really stayed with me, it was wonderful advice, was that you can do all the things, but maybe not at the same time. So there are years that are more about your clinical training. There are years that are more about science. There are years that are more about family, taking care of aging parents, focusing on your children, focusing on friends who need you. Life is long, and you get to do it all. But you have to make priorities. You have to make priority-based decisions, and you can't do everything perfectly at every moment.
Professor Michelle Monje, thank you so much. So Jenna and Tamri are here with Mike, so you should feel free to raise your hand and they'll see you.
So this is more of a personal question, but my mother, after she became a mother, she used to say she viewed children differently. And I wanted to ask, as someone who works with pediatric neuro-oncology, how becoming a mother impacted your view of your job and your relationship with the children you were taking care of?
It's a great question. I will share that my job became a lot harder after I had my own kids. And there were times when, we spoke earlier about how, there is this very heavy emotional toll that caring for critically ill children places on the providers. There were times when a patient would remind me of my child, be the same age as my child, have the same characteristics as my child at that point, and it was very difficult for me to care for them. I never had to give up caring for a child for that reason, but I would in those cases I would have nightmares. It would really, really affect me. And sometimes, we don't work in a vacuum. We work in teams in medicine, and there were some patients that I could see were too close to my colleagues' children's age, or that they would see were too close to my child's physical appearance, something that we knew would make it a little more personal, a little harder to deal with, and we would take those patients for each other to make it easier.
Thank you so much for your presentation, Dr. Monje. I have a pretty technical biology question. So in your paper, The Neuroscience of Cancer, you talk about this really interesting connection between loss of membrane depolarization and the spread of cancer. But after I dug deeper, it seems like this is a pattern that's apparent in not just brain cancers, but also multiple types of cancer.
Yeah.
So I'm wondering whether you think there's some deeper pattern here. It almost seems like there's some sort of convergence from multiple different cancers to rely on loss of membrane depolarization.
Thank you for asking this question. So just for, number one, the nervous system, as I mentioned, really importantly drives the growth of numerous cancers. And it turns out that, as you might actually just intuitively think, the nervous system is critically important for regulating the behavior of the stem cells that generate our tissues and organs during development, during regeneration, even just for sort of healthy maintenance. And cancers don't really invent much that's new, if anything. They just take advantage of kind of existing systems and processes. And membrane depolarization triggers a number of intracellular events. Different cellular contexts, are sort of differently set up to respond to membrane depolarization. But there are voltage-sensitive, ion channels and other kinds of sort of voltage sensors in many different cell types, and that can trigger a cascade of intracellular, signaling events that are critical for either regulating gene expression or proliferation or survival, and the cancers, I think, are hijacking that. So yes, we've studied it first in the primary brain cancers, whereby membrane depolarization very robustly drives the tumor growth. That alone, that part of the signaling alone. We're trying very hard now to understand those intracellular consequences, like what are the voltage-sensitive mechanisms of growth. But it is not at all restricted to primary brain cancers. We see the same thing in cancers when they are metastatic to brain, and the same kind of biology is likely at play in cancers outside of the nervous system that just haven't been studied as closely as those inside of the nervous system in this exact way. It's a great question.
Thank you very much, Dr. Monje, for your talk. So one of the characteristics of DIPG and DMG are the fact that they are diffuse cancers. Mm-hmm. And I know there are lots of other types of like glioblastomas which are not diffuse. Mm. How does this difference between diffuse and solid tumors affect the way these tumors act and how they can be treated?
Great question. I'm glad you gave me the opportunity to clarify that glioblastoma is very diffuse, but there's also a nodular component, right? And most of the biology, most of the focus has been on that nodular component that our surgeons resect and that isn't the problem for the patient. Why do people die from glioblastoma? They die because the glioma cells diffusely infiltrate the nervous system and cause circuit dysfunction. It is a very similar disease, but there is this difference of there being the initial nodule, right? The biology is very similar with respect to the way that the tumor cells interact with the nervous system. There are synapses that form both between GBM cells and neurons, as well as from DMG cells and neurons. And the initial molecular drivers of GBM and DMG are different. If we think about these tumors kind of like a fire, there's a different match or a different electrical spark that triggers them. But once the fire starts, they burn very similarly.
Hello, thank you for your talk and your time. I'm curious as to how technology has changed your research from when you first started your lab or when you were being educated, and how you anticipate technology will be used in the future to lead to more discoveries.
Yeah, it's been an exciting time to be a scientist. 15 years ago, when I was a postdoctoral fellow, the technology, a variety of different kinds of technologies, let's take sequencing for, genomic sequencing as an example, was such that we could ask targeted questions based on hypotheses. And that's still a critically important part of science. But in addition to that, because of technological advances, we can now do broad, unbiased screens much more easily and much more quickly that generate dozens of hypotheses that we can then follow up in a more facile way. And so there's been a real, I think, technology-driven acceleration of discovery, and it's very exciting. I mean, there's really just huge amounts of data being generated in laboratories right now, exponentially more. And then, of course, we have to use technology sometimes to analyze that data and to, apply things like machine learning, approaches, computational approaches, to even glean all of the different potential, discoveries that are in those data sets.
Hi, thank you so much for your talk. I was wondering whether you had any advice for someone who is choosing between many diverse different interests which don't necessarily kind of overlap.
I think my advice is, again, you have to choose what you love the most. Really, I think people succeed pretty consistently doing the things that they care the most about, that bring them the most joy in different ways. And so, it's hard. There's so many incredibly talented people here in this room. I imagine each of you is really good at many different things. but there's probably one thing that you enjoy the very most.
Hi, thank you for your talk. I was wondering, when you're talking about CAR T cell therapy, currently, like, we're very much focusing on CAR T cell therapy and immunotherapies in cancer treatment. What direction do you expect, like, cancer treatment technology to move towards, and if there's going to be, like, new sort of technologies that are going to pop up?
Yeah, I think, and I with a disclaimer that I think this because it's, the field that I'm so deeply involved in, but I think that there is a pillar of oncological therapy that we've been largely missing, and that's targeting, the interactions between the cancer and the nervous system, broadly in cancer. There's a huge number of therapeutic opportunities there, not as standalone therapies, but to be combined with immunotherapies, with other more traditional, cell intrinsic vulnerability targeting therapies. And there's already existing drugs that can be leveraged. And, I spoke about our CAR T cell trial. I've also, begun trials to look at some of these, neuroscience-inspired strategies. And I think ultimately we're going to be combining these different strategies to achieve more durable, more effective, outcomes for cancer patients.
Hi there. Thank you for sharing today. Do you see an opportunity to apply your research to a potential cure for neurodegenerative diseases like ALS?
That's a great question. I think that the real benefit of fundamental research, of basic inquiry, is that there are applications to disease processes you might not have anticipated. This dysregulation of the way that cells interact with each other is important not only for cancer therapy-related cognitive impairment and kind of brain fog, but also likely is an important component of neurodegenerative diseases. We have recently begun studying some neurodegenerative diseases. There are primary neurodegenerative processes that can then be mitigated or modulated, by these kinds of cellular states and cellular interactions. And so, how those two things interact and intersect is something that we're trying to understand. Can you accelerate neurodegeneration through these kind of, processes of dysregulation, tip over, from a compensated system to a decompensated system, and can that modulate outcomes? So it's a great question, and again, when you understand the basics, you see the applications in many different places.
Thank you so much for the talk today. I was wondering, with regard to aspiring researchers specifically, do you have any advice for either what we should focus on or advice that you wish you'd had when you were working all the way through school? I feel like I don't want to be on repeat, but I really do think, following the path that in science that makes you the most excited, that you feel the most passionate about, and trying to gain a diversity of perspective for that path. So I think that one thing that I accidentally did that I would advise everyone to do who's interested in science or medicine, with purpose, is to try to learn at least two disparate fields that when you uniquely combine, you achieve kind of a new perspective. And so I think one thing that I see students commonly do is stay in a path that they're comfortable with, staying in biology field A and for their PhD, and then going on to their postdoc in this exact same, going to their mentors, closest collaborators, laboratory. It's really powerful to do something very different, but that you see the relationship, with. And then when you begin your own research program, you've combined in a very unique and powerful way two previously, siloed fields that can come together. So I always encourage people to explore, to do what you love, but to try to do it in different ways.
Thank you for the amazing talk. Has there been a time in your career with research specifically that you've faced failure and had to shift direction, and can you tell us a little bit about that?
Absolutely, often. And I think this is an important thing to know, is that, success looks like success is just a sort of series of failures until it's not. So it's all part of that journey. And I think, one way to look at failure is not to see it as a failure, to see it as, achieving knowledge about the direction not to go. I think, gosh, there's so many examples of this. It's important, number one, to really understand how much perseverance you need in science. That part of finding the thing that works is trying 10 things that don't. And not to see those failures as, well, this didn't work, I failed, but I'm gonna check that one off, I'm that much closer, that's not the direction to go. It's important to kind of see it as part of that process. That's one kind of, not fail, it feels like failure. It's not failure, because you still learn something. And so one thing that helped me with this is to design experiments where either way, whatever I found, it was going to be interesting, right? Like, it'd be a little more interesting if the hypothesis was true, but if it wasn't true, that was still important. And you design experiments to test it, and then you look kind of dispassionately and say, okay, I learned that. Okay, now I've got to, sort of revamp how I'm thinking about this, but I couldn't revamp how I think about this unless I had done that and gotten that sort of negative data, which is very valuable. The other thing to know is that, in the kind of, so there's the experimental failures, there's also, submitting your passionate, years-long work to a journal and having it be rejected, or having a grant not funded, or all the things that we have to face. And it is okay. It is also part of the journey. The first paper from my lab was published in Science. It was really exciting. It was rejected 5 times before it was published in Science from 3 different journals. It was a lot of failure until suddenly it wasn't. And so, you just got to keep persevering, keep stepping forward, know that this is more of a marathon than a sprint, and see the value in what you learn, whether it's what you expected to learn or not. Yeah.
Thank you so much for speaking with us today, and thank you so much for bringing visibility to being a mother while being a scientist. That really means a lot. I'm a sophomore now, which means that I'm exploring a lot of fields. Like, I feel like there's an infinity of fields available to me right now, especially being at Stanford. So I'm really curious to know, what were you doing in your career before you went into medicine? And once you went into medicine, what introduced you to neuro-oncology?
I told you that story earlier about that professor who kind of helped me pivot back to science. And I joined her lab, and I idolized her, and I studied what she studied, which was neuroscience. And I loved it so much that I basically stayed on that path. So it was pretty linear. I studied, in her lab, she studied the way that loss of oxygen and glucose makes neurons die. She studied stroke. And so I studied that with her. And then I came to Stanford and kind of knew I wanted to study neuroscience, still exploring, wanted to keep an open mind, went through my clinical rotations and realized that, yeah, I love OBGYN, but it's really the neurological complications that I'm most excited about. Like, I love surgery, but it's the neurological stuff it was neurosurgery that I liked. Loved, family medicine, but it was really the neurological cases that I was so drawn to. So it was clear to me that that's what I wanted to do. And so I did a PhD in neuroscience. I did a PhD in a topic that was kind of inspired, as I think everything in my career has been, by patients that I took care of. And while I was doing my PhD, I stayed clinically involved and did a continuity clinic in pediatric neuro-oncology because I had a wonderful mentor there.
And it was just seeing a patient that, I decided that's what I was going to do. It was this patient with DIPG. I thought, I can't turn away from this. I have to study this. Somebody has to study this. And I think I'll be good at it, so I'm going to do this. And I'm going to open up this dark box and, look inside and shine some light in it, because it's not acceptable to have nothing to offer these kids. Yeah. So, mixture of serendipity and following, interest.
Hi, Professor. I'm in the back. I wanted to ask which students you think would make good fits for an MD, PhD, given the trade-offs and this kind of need to follow one passion or specialize a little bit. And then also, maybe if you could just talk about the trade-offs more generally in your experience with that.
So I think that there are people who just love taking care of patients and want to do that all the time, who should focus on clinical medicine. And there are people who love discovery and love science and love being in a laboratory and basic science, and they should do science and do a PhD. And then there is a smaller group of people who really are comfortable at the intersection between the two, who want to take care of patients and want to have that clinical perspective, but also want to pursue fundamental questions and put in the time and the training necessary to, do good science. And that's a powerful position to be between those two worlds of clinical medicine and basic fundamental research, in which you can, in a very focused way, and I think that's important. It's important to focus so that you can balance all of the things. You can translate, discoveries from the laboratory to patients. You can learn from patients. You can have hypotheses generated by your patients and bring them back to the lab. It's very bidirectional, but it's not for everybody. And I think it's only for people who truly love both. And so, I think you have to kind of go down the path and just see what really gets you up in the morning, what you really enjoy doing. And people discover, during medical school that they don't really like seeing patients, and they end up spending most of their time in the lab, or they discover, during a PhD that they don't love being at the bench, but they're so eager to see how what they're studying affects patients and to be at the bedside. And then there are people who are very happy running between the lab and the bench, and the bench and the lab and the bedside and the clinic, and really need to see their work translated and to have their work be inspired by patients. So you have to sort of travel down the path a little bit and see which roads seem most attractive to you, which forks in the road.
Hi, thank you very much for the insightful conversation. I was wondering if you can share a bit about your thoughts on BCI, brain-computer interface, and also like the scientific community's opinions towards it, and whether it shows promises in your opinion. Thank you.
Brain-computer interface is a really exciting aspect of science and medicine that I think really exemplifies that concept of merging two seemingly disparate fields. People who have neurological injury that prevents them from being able to move, being able to apply engineering and computer science insights and perspectives to the neuroscience, to achieve some control through brain-computer interfaces is incredibly exciting. And I've seen just enormous progress in that field here at Stanford in the last couple of decades. I think it's very hopeful.
So thank you, doctor. I have one more question. So as a child, I was diagnosed with a brain tumor, and I was wrongfully diagnosed, like it was medical malpractice. Mm-hmm. So it's something that's really affected my life, and I wanted to ask you, like, what strategies do you envision to tackle medical malpractice, especially in the field of oncology?
I think that improvement in diagnostic technology is one area that helps guide away from mistakes. I think that the increasing practice of referring childhood cancers, 2 centers of excellence for those cancers where misdiagnoses are caught is incredibly important. And there's been a lot of investment in the last couple of decades in technology to make diagnoses much more accurate. And before, really, we looked at tumors and said, well, it looks like this. It looks like this under the microscope. It looks like this on the MRI scan. Now we have technology that allows us to look at the epigenetic profile, the methylation profile of that tumor, and allow it to be classified in a way that sometimes surprises us, but helps to spare kids from therapy that is harmful, that they don't need. So I think that technological advances and the increasing practice of reaching out to true experts helps to avoid that.
Michelle, thank you so much for being with us today.